Good afternoon and good evening. Welcome to the IOMP School webinar. It is amazing to see the tremendous participation from over 700 of you throughout the world. We welcome you to this webinar on why radiation oncology clinical trials need medical physicists. My name is Kwan Hoong from the Universiti Malaya, Malaysia. I'm also the chair of the IOMP Awards and Honors Committee. With me, my co-moderator, Wayne Beckham. He's from BC Cancer from Canada. And he will introduce our two excellent speakers, Søren Bentzen from University of Maryland and Tomas Kron from Peter MacCallum Cancer Center in Melbourne. Now, we all know the RCT randomized control trial remains as a gold standard for establishing causality between intervention and a clinical outcome. And medical physicists have been playing an important role in clinical trials, and in some instances, even taking the lead in them. However, not many of us or our clinical colleagues are aware of our role, and thus we organize this webinar with the objective to help all of us to understand the various approaches to clinical trials and to understand the importance of clinical trial for generation of evidence in radiation oncology, and also to appreciate the multiple roles of medical physicists that can have in a clinical trial, and lastly, to explore where this can result in more than a supporting role. And now let me hand on to my co-moderator, Wayne Beckham, to introduce the speakers. Wayne, please.
Thanks very much, Kwan. It's my great privilege to be able to be part of this session today, and it's a great privilege as well to be able to introduce two fantastic speakers who generally probably don't need a heck of a lot of introduction to many of you because they're so well known. And I just personally want to thank both of them for agreeing to help us with our objectives today. So Professor Bentzen will speak first, and he's had a long career at the interface between radiation biology, medical physics, biostatistics, and evidence-based radiation oncology. And he's only one of three individuals who's been awarded both the ASTRO and ESTRO gold medals, with over 550 papers and book chapters and 400 invited lectures. It's a wealth of knowledge and information, and certainly relevant to the discussion this morning. He'll provide some great background in terms of clinical trials. Tomas Kron, great colleague of mine over many years from Melbourne. He specializes in the education of medical physicists, dosimetry of ionizing radiation, image guidance, and clinical trials. He's been principal investigator in several clinical trials and has also been awarded the Order of Australia Medal for Services to Science and Medicine. He as well has over 350 papers and 100 invited lectures. The idea here will be to have both the speakers present their talks, and we'll respond with a question and answer session at the end once they've both finished. So if I could hand over to you, Søren. Thank you very much.
Yeah, thank you very much, Wayne. Thank you for that introduction. Let me just dive into my slides if I can share. Yeah, okay. So yeah, thank you very much, and thanks for giving me this opportunity. As you all appreciate, this is a topic that is very, very close to my heart. And one way or another, I have spent the last 45 years working in this space. The way that my friend and colleague Tomas and myself have divided it up, I'll try to make the case why radiation oncology needs trials. And especially with all the current advances in data science, in AI, in large language models, you name it, it's a good question why the controlled clinical trials still holds this status that it does. And I'll try to argue that we still need trials, and that's not going to change anytime soon. And then Tomas will cover in slightly more detail the many roles that medical physicists can play in advancing trials and ensuring a higher quality and more information derived from the trials that we manage to do. So at the, I'll see if I can get all this to work. Can I advance that? Yes. So at the very heart of this is the idea that you can improve medicine through systematic experimentation. And I would be the first one to admit that large parts of what we do in medical practice is not based on any kind of evidence from trials. A lot of medicine is transactional. You go to your doctor, she will write you a prescription or refer you to a specialist, and evidence doesn't really come into it. But at the end of the day, we need to be able to distinguish between strategies that represent good value for money, where there's a net benefit for the patient and where the benefit is somehow proportionate with the cost of a treatment. And that's really where you need trials for comparative effectiveness and for cost effectiveness comparisons. There's really no other known method than trials. And I'll try to get a little bit into the argument for that statement. Now, the idea of controlled clinical trials is really an old idea. It's at least in the modern sense 1,000 years old. Ibn Sina was a physician and a chemist and lots of other things, naturalist, who lived around year 1000. And he wrote a very influential canon of medicine. It played a big role. It was translated into Latin and played a big role also in Western European medicine for centuries, seriously. And at that time, a lot of medicine was based on case stories, people who had done something in an individual patient and then seen a dramatic regression of a disease or improvement in the patient's condition. And they put way too much emphasis on these kind of case reports. And what Ibn Sina did was that he criticized that way of making deductions, and instead he proposed what he called a method of experimentation as a means for scientific inquiry. And that was essentially what today we would call the controlled clinical trial. So it was the idea that you would compare patients who received the treatment with individuals who did not receive the treatment. You would try to isolate the causal relationship between receiving the treatment and then the disease state or the disease outcome. And he would do that in a formal trial, or he proposed to do it in a formal trial. And relatively recently, there were attempts in the late 1800s at doing what essentially today we would consider randomized controlled trials. They often used alternating dates and so on. So in a modern lingo, they would be pseudo-randomized, not truly random. But at the very least, the intent was to avoid selection bias and randomly assign groups of patients to two competing treatment options. And one of the pioneers was a Dane, actually, and being a Dane myself is the one I have on my timeline here, Johannes Fibiger, who proposed and conducted such a trial, a relatively large trial, actually, with around 210 participants that he conducted in the late 1890s. And then it really took off thanks to Sir Ronald Fisher. Fisher had this idea that you could do what we would call a Laplacian trial. You would do a trial where it was entirely probabilistic whether you would go into one option or the other option, and that became influential. In the late 1940s, we have the UK Medical Research Council's streptomycin trial, and a lot of people would argue, and with some justification, that this was the beginning of modern randomized trials. It should perhaps also be mentioned that the first radiation oncology trials followed very, very soon after. Some of the adjuvant radiotherapy for breast cancer, where they compared extensive radical mastectomy versus simple mastectomies plus radiotherapy, they were conducted as early as 1950 and reported in the late 50s. ECOG, the Eastern Cooperative Oncology Group, was formed in 1955. The URTC came in 1962. The RTOG came in 68. And then in the late 80s, in 89, the Cochrane collaboration was formed. And the Cochrane collaboration was a large volunteer network of physicians and trialists and statisticians who tried to do a big push to promote evidence-based medicine in all aspects of clinical practice. And one of the examples that I'm going to discuss in a few slides is the UK post-op breast fractionation trials, where in a sequence of trials, we managed to randomize more than 15,000 patients into different dose time fractionation schedules. And I'll try to argue that has really moved our clinical practice in what is still one of the major indications for radiation therapy. At the time when these trials were started in the UK, 40% of all radiotherapy fractions were given in that indication. So it has huge consequences, what you showed in trials like that. Now, why don't we just do basic research? Why don't we just find out how the world is put together and then design treatments accordingly? And there are several good examples. This is an example that I think it's good to know. When EPO was invented, recombinant human erythropoietin, it was realized that that had a huge potential in professional biking because you could dope people who did bike racing, but also in cancer research, because at that time, numerous studies had shown that there was a negative effect of having anemia or a low hemoglobin concentration in patients who received radiation therapy. And a lot of the clinical data were particularly strong. There were data in other diseases, but they were particularly strong for squamous cell carcinoma of the head and neck. It was quickly realized that also in humans, EPO can increase the hemoglobin concentration. And it was shown by Robert Levy already in 93 that if you gave EPO during fractionated radiotherapy, that would indeed increase the hemoglobin concentration in a patient. So the time scale and the effect size was such that it was measurable during a course of radiation therapy. And then a number of groups did animal experiments. They had small animal models with induced anemia. And again, they were able to do dose response curves. And they were able to show that if you used EPO in experimental animals, then you could improve the response to radiation therapy. So you can see how they gradually built the whole case that EPO can stimulate hemoglobin. Low hemoglobin is bad. We can manipulate it in patients during clinical radiotherapy. In an animal model, it actually is associated with an increase in radiation response. So what's not to like? Some people would even argue that maybe we didn't need a clinical trial because we basically understood all the parts of this system. And guess what? This is the trial by Michael Henke and his colleagues in Germany. A large randomized controlled trial. It was placebo controlled. 350 head and neck cancer patients were randomized. It was blinded. You were randomized to placebo or to EPO, and the endpoint was local regional progression-free survival. And when they broke the blinding, guess what? You had actually been lucky if you had been randomized to the placebo arm instead of the active drug arm. And later on, Henke's group did experiments showing that one problem that had not been anticipated from all the preclinical work was that EPO actually acts as a tumor growth factor. So it actually stimulated the growth of the squamous cell carcinoma cells during treatment, and therefore there was a negative effect of getting it. And it's not just this trial showing a spurious outcome or a fluke outcome. There has been at least a handful of trials reproducing Henke's trial, and essentially all showing that placebo is better than the active drug in this case. So that's the problem. It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. All the things we believe that protons must be superior to photons. We believe that chemoradiation therapy must be better than radiation therapy alone. We believe whatever. And how do we really know unless somebody does all the hard work? You need a lot of work. You need patients to volunteer. You need a lot of clinicians in a network. It is a lot of work, but that's how we really learn if there's a causal relationship between a treatment and a specific outcome. So the first motivation for doing trials is that we would like to know. We would like to know if a given treatment is actually better than the alternative. But the other pressure comes from the multimodality oncology colleagues, doesn't it? This is a study from Medicare, Medicaid in the US. They looked at the increase in expenditure corrected for the aging of the population. This is the percent share of different medical fields of the total expenditure. And this is the growth in spending from 2003 to 2009. And radiation oncology is not a big expense for Medicare, simply because radiation is not given to so many patients. Internal medicine, cardiology, and so on are the big spenders. But we are good at something, huh? Because we actually have the highest growth rate over this period of time of any field in medicine. There was a 300% net growth in the spending on radiation therapy over this period of time. It had to do, of course, with the rapid uptake of IMRT in the US and the favorable reimbursement of that modality. Maybe too favorable seen in hindsight, but that's a different story. So although we are not big spenders in this overall map, we are under pressure. All the time you need to argue that this is value-based clinical medicine, and that argument requires trials. So evidence-based medicine in the simplest definition is the consensus, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And that's a good definition. That's what it's all about. It's about whether or not there's a net benefit from a given intervention compared with the alternatives. It has been twisted and turned. Whenever something is successful, somebody will have to change it. And that has happened. There are all kinds of flavors of this. I personally like Sackett's 1996 definition because I think that gets right to the core about what this is all about. And this in turn has led to the clinical practice guidelines. We have lots of those also in radiation oncology, and there are even instruments to evaluate the quality of guidelines and trials and so on and so forth. And what is characteristic for all these many systems of quality ranking is that at the high level of this evidence pyramid, you have randomized controlled trials or even meta-analyses of multiple randomized controlled trials that are showing consistent results across the individual trials. Now, I'll also very briefly, I won't go into the details in the interest of time, but I'll also say that what randomization does is that it isolates causality and it really guards against selection bias. There are other types of biases. Maybe in a proton arm of a photon versus proton trial, you do more weekly scans of the proton patients, or you do more follow-up clinics for whatever in a chemo arm than in a non-chemo arm. So you can also have performance bias, you can have detection bias, you can have attrition bias. Depending on trial designs, it could be that the patients who continue to be on a study gets more and more selected in one arm compared to the other arm. That could be the case when you do a per protocol analysis where you compare against standard of care in the control arm. There's also a lot of discussion that is slightly misplaced. A lot of people say, yeah, but randomized trials, the populations you have in trials, they don't really look like the patients we treat in our clinic. And that's probably true, but that is confusing external validity with internal validity or generalizability. External validity is whether what you see in the trial can be translated to the general population. But the internal validity is whether you have a biased assessment or not when you isolate the effect of the intervention. And the internal validity, you want to do that in a relatively homogeneous group, simply to reduce the variance in the two arms, which will then reduce the number of individuals you need to include in your trial. Let me show you briefly the fractionation story. Back in the 70s, there were lots of clinics in the Western world who introduced resource-sparing hypofractionated radiotherapy. This particular patient was one we saw in the clinic in Aarhus. Mario was the physician treating the patient. And this patient came back with a contralateral breast cancer after a mastectomy and radiotherapy. And then she had a second tumor in the contralateral breast, and again she had a mastectomy and she had radiotherapy. So she is her own control, if you like. This idea that patients will vary in how they respond to radiation therapy, that is true, of course. But this lady was actually treated first on her right-hand side. And you can see that there's much less skin reaction on the right-hand side than on the left-hand side. So despite the fact that these reactions progress over time, the side that was treated 2 years before her left-hand side is the one that shows the best cosmetic outcome. And the difference was that people had reduced the number of fractions between the two courses of radiotherapy. Her first course was given with what we would call standard fractionation, around 2 radiofraction, and this was given with hypofractionation. The lady has been asked to raise her arms maximally, and what really bothers her is probably that she can raise her arm fairly well on the right-hand side, but she has reduced function on her left-hand side. She has what we call the frozen shoulder. So at the early 80s, it became widely accepted that probably hypofractionation was a really bad idea. But if you look historically at this, you cannot conclude that you cannot hypofractionate. You can just conclude that they were over-treated with the large dose per fraction arm. And that was where all the UK breast fractionation trials started. And again, time doesn't allow me to tell you the full story. It's a fascinating story. It's something as a discipline we can be extremely proud of. Also, all the physics and QA was exemplary in the START trials. There were many inferior treatment techniques that were weeded out just by the fact that this was a nationwide controlled trial with protocol-specified prescription and treatment guidelines. But just see how this works. You have test arms and controlled arms. As you accept a new standard arm, that becomes the new control arm. And at the end of this long period of time, more than 30 years, you have randomized 15,000 patients. And step by step, we have learned about the dose time fractionation of subclinical breast cancer. And now we can go back to the 1989 review by the Royal College of Radiologists. These blobs are proportional with the number of physicians who prescribed a given type of dose fractionation. So this is 50 gray in 25, this is 40 gray in 15. This Pareto front are Pareto optimal schedules. If you are on that front, you cannot improve tumor control without compromising normal tissue toxicity or vice versa. You cannot improve one objective without compromising the other objective. So a schedule like this down here is very bad. That's a bad schedule because it's hot on the breast, but it's not very hot on the tumor. And you can actually convince yourself that the Euclidean distance from this point to the Pareto front is exactly how many grays you could gain in such a case by moving them to the front. So you can go hot or you can go cold. If you go hot, you will have more toxicity, but you will also have more effect on the tumor, and vice versa. This front is where you want to be. And this is the new fast forward study. So with all the progress in data science, and this is really what I would like to round off the presentation today, telling you, and again, this is an example, some of you may know it already because it's so nicely done. It came from a study conducted at the MD Anderson. What is in the reference here is the primary reference and not the paper where Jordan and her colleagues discussed this case. But look at this. This is observational data. Look at the numbers of cases. 33,000 men had active therapy and nearly 11,000 had observation for low and intermediate risk prostate cancer. And this is the adjusted survival, and this is the follow-up time in years. So observation only, this is the survival probability as a function of time. If you get radiation therapy, you do slightly better. And if you get surgery, you do much better. And everybody, of course, likes this paper. It was published in JAMA, which by all means is a decent journal, and it has been cited a lot of times. So watchful waiting is inferior to active therapy. And of course, the authors were not stupid. So they looked at a regression model. They adjusted for the year of diagnosis, the age of the patient, the race, urban versus rural residents, marital status, income, education, you name it, tumor size, tumor grade, comorbidity score. They did a propensity score analysis. It is still there. Active therapy was superior to watchful waiting, observation alone. And look at the hazard ratio for all-cause mortality. So you can reduce the all-cause mortality by 32% by treating these men actively. But wait a minute, down here they look at the hazard ratio for non-cancer mortality. And it's hard to understand why that would also drop down to 2/3, isn't it? You can understand why treating the prostate cancer is probably a good idea in terms of your life expectancy, but why would it improve your non-cancer related survival? And then Giordano, and she's the lady from the MD Anderson who deserves all the credit, she took a non-cancer control group. So she did age-matched men who never had a prostate cancer diagnosis. And guess what? If you never had a cancer diagnosis, a prostate cancer diagnosis, you also did better than observation. You actually also did better than radiation therapy, and maybe that's fair. But you can see that you did much worse than patients who had radical prostatectomy. So this is all about selection, isn't it? It's not about causation, it's about selection. When I show the slide, I normally say to the men in the audience that they should consider having a prophylactic prostatectomy because they will live much longer than if they keep their prostate. These men are selected. They are all the good players, huh? And that's why they do better than radiation therapy or observation, but also why they do better than men who never had cancer. So we're coming to the end. I would just at the very end say there's a lot of interest currently in what is called embedded pragmatic trials. It's the idea that you ask patients for consent for randomization. It was pioneered by several groups, but one of the groups was a large national Swedish study who compared two procedures for managing patients with myocardial infarction. And the idea is that you use registry data for everything except the assignment to the two treatment options. That's exactly randomized. The follow-up is done via registry data. 7,000 patients randomized. The endpoint was 30-day mortality. The cost per case was $50. Seriously. Essentially, some research coordinators who randomized the patients. And now they know, they could actually compare the two in a strictly randomized setting. So for technology, the challenge, and I'm sure Tomas will dive into this, is what we call Buxton's law. It's always too early until, unfortunately, it's suddenly too late. The idea is that technologies get introduced in the clinic long before they are ready for prime time and examination in a trial. And that's a big challenge. They are not going to go away once they are established. So hopefully Tomas will discuss that as well. But I think in the interest of time, I will just wrap it up here, and I hope we have time for questions at the end.
Thank you so much, Søren. That was a wonderful presentation and so much knowledge there. Wayne, are you happy for me to just get started?
Yes, Thomas, go ahead, please.
Excellent. So let me share my screen. You should now see a screen with IOMP on it, and I'll make that even a bit bigger for you. So here we go. So welcome to the second part of this presentation. And I must admit, I have a much more pedestrian presentation, and that is a bit more focused on physicists as well and their particular role in clinical trials. But before I get started, I just want to tell you where I'm from. I'm from Melbourne. I work in a very nice new cancer center, Peter MacCallum Cancer Center, and we are also a rather large organization, as such, operating on 5 campuses with 16 LINACs. What is important for this presentation, though, is first the declaration of potential conflict of interest. I think if I tell you something, you always need to question that, which is very similar in clinical trials and distinguishes between investigator-driven trials and trials which are, for example, sponsored by someone who may have some stakes in that trial. So I have a research collaboration with varying medical systems. The other thing which is relevant for our presentation here is that we are organized in tumor streams. And that basically is a result of just being big. That means we can subspecialize. And that means also physicists are subspecialized. And my particular areas of interest are lung cancer and breast cancer. And I can attest that the trials Søren was talking about, the UK post-op trials, have really not just changed practice in England. They have changed practice all over the world. They were probably some of the most discussed trials in our environment. The objectives of my presentation are really to review the objectives of clinical trials, discuss a couple of practical examples, in particular where physicists are involved, and then reflect why physicists may want to be involved in running trials. So, what are the objectives of a clinical trial? I sort of say that a bit flippant as test something new or compare several options in a well-defined cohort of patients. And Søren has already mentioned the issue of a well-defined and well-characterized cohort of patients. But I just want to invite you also briefly to reflect on what you are doing when you are introducing new technology in your clinic. Sounds actually pretty similar to what this here all is. And of course, a clinical trial stands on the shoulders of a whole lot of other work which has been done before. A clinical trial doesn't just fall out of thin air. There need to be ideas, science, lab work, preclinical studies. One needs to get funding and get interest from all the punters out there. Ethics, governance, and a whole lot of other things need to be all in place before we can get to this clinical trial. But then we can actually look at this comparison between the several options in a well-defined cohort of patients. There are a couple of other characteristics in a clinical trial which are worth mentioning. It needs to be a good and relevant question. There need to be well-defined interventions, not just well-defined cohorts of patients. Standardization across centers, if we invite several centers to participate in there, and then a prospective collection of data. And I've just underlined prospective because it took me actually 20 years of being a clinical physicist to understand why prospective collection of data and actually saying before you start what you are going to do is a very nice way of trying to minimize bias. And then I also would like to draw your attention to this commitment to publish, which basically means that we will or should try to publish even if the trial is negative, even if we think there is really nothing new, because unless otherwise we would only publish successful trials and the world would be full of successful success stories, but not really characterize the world as it is in real life. Now, if I look at these characteristics, then 3 of them are really right there where the physicist would be well-defined interventions, standardization, and quality data. So let's just have a quick look at interventions as such. And it's probably fair to say that our understanding or our way of doing clinical trials is mostly really geared towards drugs. And this has a whole variety of historical and also financial reasons. Drug companies have a very vested interest into that. The funding mechanisms of clinical trials leading to funding is well outlined and well tread. And the complexity of humans makes these trials really essential. Another advantage of drugs is that toxicities or some outcomes are typically quite acute and therefore quick. In radiotherapy, that's not necessarily the case. And the breast cancer patient with telangiectasia, which Søren showed, that would have been something which isn't coming a day after radiotherapy. This is something which will be rather late. That makes clinical trials more costly, longer, and more tricky to do. And then we have the problem that technology as an intervention is often intuitively judged as an advancement. Why do we need trials for parachute use to prevent death and major trauma related to gravitational challenge? And this is a very commonly cited paper here of a meta-analysis which tries to do something rather silly to actually look, are there any clinical trials which randomized to parachute use or non-parachute use? And obviously there are none. And that makes obviously good sense because there's something like obvious evidence here on the left. The complexity on the other side would compel us to do clinical trials. So it's really on this sliding scale where we need to look at what tools we want to use to identify what the evidence is. So I would argue that the parachute use is somewhere here where the intuition or obvious outcome is fairly clear. The blunt with a sharp scalpel is potentially a bit further to the complexity because you can do quite a lot of damage with a sharp scalpel as well. But drugs are mostly really here. If you put a drug in a patient, there are so many complex pathways, and it is something which clearly requires clinical trials. Our question then becomes, where is technology located on this continuum of evidence? And if one looks at, for example, an IMRT plan versus a 3D conformal plan, there one could sort of say that, yes, there seems to be some obvious evidence, and it would obviously be quite difficult to go to a patient and tell the patient, well, we randomize you to either this or this. So equipoise in a clinical trial like that is not something which comes naturally. And it is something which needs to be discussed, needs to be also openly discussed with the patient. And as you've seen in the trial of EPO, Søren Bentzen has shown there is potentially much more uncertainty around there than a simple picture like that would make you believe. If we go back to the physicist and new technologies and techniques, then I'm excited being a physicist that they are part and parcel of radiation oncology. They are always exciting, at least for me, and possibly difficult to implement. But are they surely better? This is clearly one of those questions we need to ask. And they are often not cheap, which basically means we have to have some sort of risk cost-benefit analysis. And that's clearly where the physicist comes in handy. And questions like, is the new technology safe? Does it work? And is it better than what we have so far? Better potentially on all dimensions, including a financial dimension, are things physicists are very good at. It also mirrors really the type of trials we are doing. A phase 1 trial is typically a question about, is it safe? Phase 2 trials try to establish, does it actually do something? Does it work? Does it do what it should be doing? But it's really phase 3 trials where you compare the new with the old, which have the impact to change practice as such. And then, as Søren has already alerted to, there are phase 4 and 5 trials which actually demonstrate that things which sort of may look good in a clinical trial actually hold up in clinical practice. So we've now looked at interventions for a couple of minutes. Let's have a quick look at standardization and quality, because that is really where I think the physicist can contribute. And quality in this case would be the quality of the protocol, which basically outlines what the intervention should be. And the physicist clearly has an important role to play. Numbers are always good in these things. Unambiguity is a good thing. And physicists are in a great position to actually look at that and with the help of the statisticians make sense of numbers in that context. And then we need to ensure that once we have actually established the clinical trial and are starting to randomize patients in the trial, or just accrue patients, that the centers which participate are actually complying with the protocol, that they understand the protocol, and having a quality control program in place that ensures that everything is delivered as planned. If we do that, and all the participating centers actually do the same thing, follow the same protocol, understand it in the same way, and have similar quality assurance activities, well, then standardization comes very naturally. What tools do we have as physicists to try and make these trials better? Credentialing of participating centers in order to make sure that they really understand that the trial and that they can deliver the treatment as planned is an important aspect. Facility questionnaires help. So do dummy runs and planning exercises, and that's just a planning exercise for a clinical trial of stereotactic treatment of lung cancer. Then there are dosimetric audits, which actually ensure that the equipment in the center is fit for purpose. And the IROC group in Houston has published a huge number of papers on their dosimetric audits, and also the surprising variability amongst high quality centers in a first world country like the US, where the dosimetry is not necessarily as it seems. And then there could be site visits, and then while the trial is running, there could be a real-time review of patients as before they are treated. This is something which is particularly useful in the context of high-risk trials. An example from our clinical trials group in Trog is that we went on the road and visited some 20 centers with a phantom that was moving in preparation for a clinical trial of stereotactic treatments. And it's sort of always good to see that this quality assurance research is actually publishable. And we've published a number of papers, which basically gives not only the physicist some kudos in this whole process, but also the clinician a paper to refer to when they publish the clinical trial results. even more importantly, we are using the QA processes we are trying to implement in these clinical trials, then also in clinical practice, and do what we preach and do what we do with other centers, also then back at home. Finally, these quality assurance activities also help to make a trial shorter, better, and cheaper. And that is one of my favorite papers overall, where these guys demonstrated that quality assurance of dosimetry is really very effective in reducing the required sample size. It just defines the intervention better and makes sure that the intervention actually works as planned. Well, this is obviously not magic whatsoever. It just means that if I convolve all the different uncertainties in a clinical trial, and I can tighten the physical uncertainties, for example, of the dosimetry, my ability, my power of the trial, my ability to actually make meaningful conclusions is just improved. So we've covered now intervention, standardization, and quality of data. But I just want to finish off by asking also about the trial question. And that is something which I'm quite passionate about, because I do think that physicists can also ask trial questions. If we are looking after the invention at times, actually even invent the interventions, or at least define them in a way that they can be used, then we should also be able to ask trial questions. They are often secondary endpoints. So for example, in a trial which asks a question about a drug, a treatment with drug and without drug, we can still analyze the data in terms of IMRT versus non-IMRT treatment, or tomotherapy versus VMAT, or whatever we want, as long as there are sufficient patients. Technical questions with clinical impact are domain of the physicists, feasibility studies, health economics, and implementation science, which is sort of an emerging area of research, and that's just a multi-center clinical trial which we run, and which had the very standardized feasibility outcomes that it was feasible to do deep inhalation breath hold. Well, that's these days not necessarily a big deal. What was sort of a bit surprising and still not quite picked up is that the reproducibility actually may be worse in terms of getting to the same breath hold each time. There's more variability depending on what type of technology you use, and that could, strictly speaking, if, for example, used for partial breast irradiation, where you have a defined target, could lead to larger margins. And then we have a health economics outcome. What for me, though, was the most interesting part is really that the clinical trial also studied anxiety. And that's not something, as a physicist, I was open to start with, but I was talked into this by a consumer, or basically a former patient, who felt that breath hold means we actually ask the patient to do something, and by doing that, the patient may have more stress. And indeed, that sort of bears out in the data as such. Nothing which is outrageous in terms of the anxiety score, but clearly an indicator that patients have more anxiety. On the other hand, we also asked the patients, did they enjoy or did they think it was good that they were able to help with their treatment by taking a deep breath? And most of the patients confirmed that that was actually, in the end, a positive experience. I'd like to end up with another question, which is sort of similar to the EPO question of Søren, a question about lung cancer, which is one of the most important contributors to cancer mortality. Radiotherapy plays an important role there. Well, here you can see the non-small cell lung cancer 5-year survival rates. And once you go past stage 1 and stage 2, things are actually not looking particularly good. So should we just give more dose? What about 74 instead of 60 gray? And that was actually done in a clinical trial. And yes, if you look at the 60 versus the 74, 60 grey did better. So it's again counterintuitive or counter as we originally would have thought, and the interpretation makes that clear, that 74 grey in 2 grey fractions was not better than 60 grey as such. So there are things which complicate our decision making, and I don't want to go into the details. These trials, like the EPO trials, really kickstart a whole lot of investigations, which are really, really helpful in advancing the field overall. It brings us to a take-home message, which Søren had from a different source. I chose Porgy and Bess, but it basically means that trials have this opportunity to elicit if things are not necessarily as they appear obvious. What has that to do with physics? Well, physics and physicists are one of the groups which can help to gain more insights, and that is a secondary analysis. In this case, they basically did exactly what I mentioned before. They looked at the impact of intensity modulated radiation therapy in this trial there, and lo and behold, IMRT was associated with lower rates of severe pneumonitis. Well, this trial from a physics perspective led to an important publication, but it also has certainly in our clinic and in our environment made a big difference in terms of IMRT being now standard of care also in lung cancer. So in summary, I would like to say that clinical trials are the gold standard for generation of evidence. And there are all sorts of problems with it. Costs clearly are one of them. But they are the gold standard also for technology, and we should not necessarily take technology and techniques for granted as being better just because things get better. Physicists can make really trials more effective and the data collected better and more meaningful. I haven't talked about automation, but automation obviously is a clear tool to improve data collection, and physicists can also ask trial questions, be it secondary endpoints, which is and secondary analysis, which is clearly more frequent, or potentially even should dare to ask primary questions. So I would say that every trial management committee, as you can see here, could do and benefit from a physicist who is right at the center of attention. And I think that's all I wanted to say. I thank you for your attention and look forward to questions.
Thank you very much to both Professor Søren Bentzen and Professor Tomas Kron for such inspiring talks. And you note that they explain clinical trial with such great clarity, and we can see the relevance of medical physicists is more than just doing QA, treatment planning, and we have such a important role to play towards patient care. And thank you also for 1,200 of you who have stayed on to listen to this webinar. I think is one of the records of the IOMP webinars. And I'd like to now request my co-moderator, Professor Wayne Beckham, to conduct the Q&A session. Please, if any questions, scientific questions, please write on the Q&A session, and we see how we can answer some of your questions. Yeah, Wayne, please go ahead.
Thanks, Kwan. Wonderful presentations. Thank you, Tomas and Søren. There is a question in the Q&A around quality assurance, and it's sort of talking about quality assurance that might be applied in clinical trials that may be more complex, maybe not even exists in current clinical practice in the centers that are hoping to get involved in the clinical trial. Can you sort of comment on how to set the right level of QA up to allow the trial to be successful, but not such a burden on the centres that need to and want to participate? So maybe Tomas first.
This is really a very good question, and I think it comes down to sitting together with the clinical principal investigator, asking what the actual objectives are. And trial QA is a bit different to the QA we do in the clinic. The most important thing about trial QA is to ensure that the trial has the best possible chance of answering the question it poses. So that does not necessarily mean that the patients get the best treatment, but the QA is ensuring that the trial is giving it the best goal. And that is actually something when clinicians hear that, clinicians find much more attractive than to say, just we have to make sure that everyone is doing the right thing. Yeah. Our physicists do that as well at home. But no, the clinical trials QA is actually somewhat different. So in that negotiations, we try to be there very early, because as the trial tries to get funding, we try to make sure that the trial also asks for funding for quality assurance. Without that, things get really more difficult. And then in the end, it's a negotiation. Physicists always want to do more QA. Clinicians want to do less and get their patients onto treatment quicker. But I think there is a happy medium where we can agree on giving the trial the best possible chance of success.
Yeah, maybe I can add that it is a good question, Wayne. You have to remember that if you do enhanced QA, and especially if you do enhanced QA in one arm, it becomes part of your intervention. If you have, say, a central review of tumor pathology, and a lot of trials in the US and also in Europe have that actually, then that actually becomes part of the trial intervention. You see what I mean? Then in all future, if you want to have the same level of whatever, you would need a pathology panel to sit down and agree on the subtype of lymphoma histology or whatever the trial is about. So at some level, I think you have to cut through that and say you need to do a pragmatic trial. You need to do a trial that is realistic in the environment where you hope to apply the results. We did an IEA trial, and I was very privileged to be the PI. And it was on dose fractionation in squamous cell carcinoma of the head and neck. And we deliberately decided to allow 2D planning and 2D delivery technology. And again, you could say, why in the world would you do this in what is essentially a scientific trial asking a radiobiology question? But it was all about that external validity or generalizability. We wanted to see that whatever we did in the trial could also be implemented in a department that did not do simultaneous boost IMRT with whatever number of scans. So I think the intervention becomes part of the trial, and the trial becomes part of the intervention, if that makes sense. And I think it is a very important discussion that you need to do, as Tomas also said, at the protocol stage when you design the trial.
Interesting. Tomas, go ahead.
Yes, I think the comment Søren has made about the control group is really, really valid. When we did our stereotactic trial for lung cancer, we introduced at the same time 4D-CT, but we also used it in the control conventional fractionation. And lo and behold, the clinical outcomes were actually better than historical controls. Well, that's potentially not a surprise, but if we would have just gone to historical controls, I think we would have made an error in judgment.
Thank you. Thank you. Very, very useful thoughts there. Another question, it's referring back to your presentation, Søren. You were talking about therapeutic ratios for different fractionations in breast treatment. And Carrie's asking the question about you sort of skipped over some information around the 25 or 26 gray doses. Is there any comments you can make on that, or expand on that a little bit?
That's related to the fast forward trial, or specifically, I'm wondering. Yeah, that's an interesting trial, isn't it? And that's a very good question also, because as you may appreciate if you read the publication, they could actually see the difference between two dose levels that were seriously 1 gray apart. And you can say, gee, what in the world is going on here? And part of the secret, of course, is that if you treat in a fixed number of fractions, you run into what Rod Withers called double trouble. So it's not just that you increase the total dose, but you also increase the dose per fraction. So actually the biologically effective dose, if we calculate it like the EQD2, it would be more than a 4% increase. The 4% increase in absorbed dose would translate into maybe a 6 or 8 percentage point increase in EQD2. But it's still a very remarkable finding, and it has been seen repeatedly in similar trials. You can really detect very, very small changes in dose. And that feeds back to what Tomas discussed about the precision. Precision is again a double-sided coin. In part, we would like to reduce the variability because that gives us more power for a fixed number of patients. In part, of course, we should be careful not to wash out the difference between the arms. If the difference between an experimental and a test arm is on the same order of magnitude as the precision by which you can prescribe and plan and deliver dose, then obviously it would be very unlikely that you saw any effect of the intervention. So it really all comes together, and I would like just to enforce what Dr. Kron said. Tomas said that what the physicists are really very good at is to understand multiple sources of error, of uncertainty, the whole change. They understand radiation therapy as an anti-cancer agent. And I think the input they can give is way beyond just simple dosimetry. It's related to all the many, many steps. Uncertainty in imaging, uncertainty in planning, uncertainty in segmentation, all of it will go into the package, if you like, when you do a radiation oncology intervention. But it can be done. I think the other danger is that we become so purist that we say, no, it will never work. I think that's also a danger. We have shown again and again that we can do trials, we can randomize patients, we can get large numbers of patients in. It has been shown in Australia, in the US, in low and middle income countries. There are high quality trials in South America and in the US. It can be done. I think that's important as well.
Thanks again. I think we're at time, and I want to once again, I'll hand back to Prof. Ng to wrap the session. But I did want to just leave everybody with a thought. Tomas and Søren have shown great examples of how physicists applying themselves in clinical trials and being thought leaders in those clinical trials. And there's many physicists across the world who dedicate a lot of their careers to doing this. The interesting observation I think I would leave people with is that there isn't, that I know of, from the medical physics international organizations, any real recognition of this, I think, through awards and things. So I just think that is something that the community should think about. And Prof. Ng may have some other comments along those lines as well. But this is very meaningful work that's being done. We probably also don't train our young physicists substantially in this area as well. So I think there's some other thinking there that perhaps our educational syllabus and curricula should include some thoughts about how we bring the next generation on, where, you know, trials are going to get more complicated, potentially much more involvement is needed from physicists. So just a couple of thoughts to leave everybody with. And with that, I'll hand it back to Prof. Ng. Thanks so much, everybody.
Thank you, Wayne. To continue with that, both Dr. Beckham, Wayne, and we are in the IOMP Awards and Honors Committee, and we are trying very hard to push for the recognition of physicists who are involved in clinical trials. Often, I believe many of us have not been involved or have heard of the great clinical relevance and impact in radiation oncology. So we take this opportunity to promote that and also to encourage more medical physicists throughout the world to get involved with clinical trials in whatever way it is, and believe that by working along with radiation oncologists and surgeons, pathologists, we could make a significant improvement in the cancer care for many patients out there. And one housekeeping couple of questions asked, there will be one CME point for those who have participated fully, and please refer to the IOMP webpage within 24 hours. The information will be there. So finally, on behalf of the IOMP, also on our two eminent speakers, Søren and Tomas, and also my colleague, a good friend, Wayne, we like to thank all of you, 1,200 of you who stay on to learn, and that is wonderful, that is excellent, and we hope that we continue with this great tradition of learning. And thank you once again, and I want to say goodbye and keep safe. Bye-bye.